Welcome to the Hot Flashing Podcast. I'm your host, Anne-Marie McQueen. This week, my guest is psychotherapist Paula Rastrick in the UK. Paula is also a woman who was given extraordinarily high doses of hormone therapy unknowingly and experienced physical and emotional side effects, and has made it her mission to educate women about this and to talk about the phenomenon of women who've experienced trauma and who are highly sensitive people and what happens to them when they hit perimenopause and menopause. I spoke to Paula earlier in the summer, but I wanted to run her podcast this week because there was a special alert from the British Menopause Society about tachyphylaxis in hormone replacement therapy. Tachyphylaxis is the phenomenon where you're taking a drug and it becomes less and less effective over time. The British Menopause Society said they are aware that women are being given really high doses of estradiol. This is creating supraphysiologic levels in the body, and sometimes in some women leading to the very symptoms that they went on the HRT to avoid. Paula will talk all about what happened to her and how she's on a mission to help prevent this from happening to other women.
So this is a big moment for me because I'm with Paula Rastrick, who I came across on TikTok. And you, to me, were like a breath of fresh air on TikTok, because I'm always preaching moderation in this hormone therapy space. And that proves unpopular with some people. And then you came on saying, I was prescribed too much hormone therapy. And you started talking about trauma and adverse childhood experiences, I think, and highly sensitive people. And not all of us can take the same levels of hormone therapy. And we certainly shouldn't be taking. And I'm really summing up because we're going to get into your story. But I was like, here is a woman who knows what she's talking about and is talking some sense. So thank you just for that.
I'm glad it makes sense. It does make sense for me. That's why I'm talking about it.
I'm a highly sensitive person. I've had childhood trauma and adverse childhood experiences. So I get it. And so we can get into that. But first of all, just tell me your story. Where were you at when you decided that you got led to exploring hormone therapy? What was your sort of inciting moments?
Yeah. So it was way back, actually, before menopause was kind of mainstream, shall we say. It wasn't really talked about then. So back in 2017, I was running a business. I had just literally, in the January the 1st was my birthday. I just turned 45. Up until that point, I'd opened a new business, but prior to that, I'd had a lot of stress. And there was a lot of things going on, shall we say, in the background. I started to feel not very well. So when I talk about feeling not very well, what I started to see on social media was posts about being perimenopausal. And to be honest with you, that was quite alien to me. Yes, I'd heard of it, but not too much, not like now. And it was saying things like, are you feeling anxious? Tick, yeah. Are you feeling more irritable? Yes. Are you not sleeping? Yeah, that's me. So these types of kind of adverts I was seeing from a private menopause clinic, and it was like, oh my God, that's me, that's me, that's me. So it was local to me. So I just thought, I'll try anything, to be honest with you, because I had this business. It was a new business and I had to survive. So I went to the clinic and I was told that I was perimenopausal and that the symptoms, so I did a symptom checklist, which is something I'm really interested in, because the symptom checklist I did, I think it was 21 symptoms, and it was rated. So from 1 to 9, how do you feel? How much do you feel? And I always remember I've got my symptom checklist. I refer to it now. So I looked back on it, and the highest symptoms I had were feeling anxious, not sleeping, very low sex drive. I didn't have any hot flushes. I didn't have any of that stuff, but it was all basically around what you would call more of the mental health type of symptoms. Anyway, then I was told I was perimenopausal and that the best way to treat this would be HRT. And I was just like, look, honestly, whatever, give me anything. I've got to survive. I've got to keep going. So I started on HRT, estrogen patches and progesterone, and off I went. So over the next 3 months started to get worse. My symptoms got worse. I was deteriorating. I wasn't feeling better. I was deteriorating. So I went back and I just said, I'm not feeling, better. In fact, I'm starting to feel worse. And at this point, I was then doubled on my HRT. So I went from 100 estrogen, which is what I was started on, doubled to 200. And at this point, my progesterone was then left at what it was, right?
Just for people who aren't aware, your progesterone needs to match your estrogen to stop the growth of your uterine line. It needs to oppose it. So if your estrogen is raised, you have to give more progesterone, and that's very well known. Number two, I want to point out is that you were started on 100.
Yeah.
There are people who start on 25 and
Yep.
stay on. Like I always talk about hormone therapy. I am not a doctor, obviously, but after years
Yeah.
researching this, I'm sort of like, what's wrong with low and slow? You know, that's
Well,
the approach I take to cannabis. Why?
at the time, Amrit, you know what? I'd never even thought about it. And now what I know, having worked it out all out, it was actually dangerous to start me on high doses and then go higher, you know, instead of starting low and titrating up, because I have a very highly sensitive nervous system and my brain is more sensitive. So kind of, this is what I've worked out. And it's like, wow, this actually makes sense. So to put a very long story short, I deteriorated. I started to unravel. I was keeping my business going. And in the end, I got to the point where I was bleeding very heavily. And when I talk about bleeding, I'm saying I'm not bleeding. It's just, you know, for want of it, it's literally falling out of me, right? And it's really, really nasty because I don't know when this is going to happen. And it's just falling all over the floor. I'm sorry to be so graphic. So after about 8 months of this, accumulating with my mental health being at rock bottom, and I've been at rock bottom a lot of times in my life, and I'm a survivor, a childhood survivor. So, you know, this kind of experience, I'm used to kind of just picking myself up and carrying on, keep myself busy. I just couldn't. My body finally said, you need to stop. This is it. So just at that point, COVID came along. And then that's when I went to my GP and I said, look, I'm not well and I need help. And they said, what are you doing with this amount of HRT? And I said, I don't know. I thought this was just, you know, well, I don't understand what you mean. And they said, well, we're not giving you this amount of HRT. So that became the story of then having to come down off the HRT. I had womb hyperplasia because the progesterone wasn't opposed. So, you know, you're adding in now to this kind of very, very kind of dark time.
And it could have been like, that is the precursor.
Yeah.
You were tested for cancer and you're okay.
So I had to go through these procedures and they basically said, but I didn't know any of this. I mean, it seems now like, oh, well, why wouldn't you know? Well, I didn't know because it was years ago. And also I trusted. So I just trusted that what I was receiving was good medical care based on, but now I understand it wasn't good medical care because there was no medical history taken. It was based on symptoms. Now, symptoms, you know, this is one of my my strong points that I talk about. Every single symptom that I ticked could also be a symptom of complex PTSD. And this is the issue with just taking a symptom list, ticking it, but then not doing the backstory. Because each individual woman's got a story, right? We've all got stories. We don't just arrive at perimenopause. I've got symptoms now, guys. Okay, that's perimenopause. Here we go. It's like, no, that's not how it works. So now I think when I look back on it, well, I know that I was probably misdiagnosed, but being misdiagnosed wasn't really the issue if I'd been started on 25, would it, of Everall? Because then I would have started low and my body would have acclimatized and my brain. But the fact that I started on such high doses really, really pushed me to a very dark place. So when I then ended up having to take antidepressants because they said to me, we need to stabilize you. So to get you off the estrogen, it's kind of like, I thought this was supposed to make me feel better. So
yeah. He's like a drug addict who's high and having
that's exactly it, right? So I'm having severe side effects, right? Now, side effects of hormone replacement, nobody really talks about it, do they? They don't sort of say, look, there are side effects because it is a pharmaceutical drug. And this is the thing that I keep seeing. I'm like, guys, it's not your hormones. Like, they're not your hormones back. This is a pharmaceutical drug. And what we like to talk about is that, oh, it's natural. And I'm not against HRT, I still take it. But to give you some kind of, I was on 200 and I'm now on 50 and I'm great. I'm not anti-HRT. I'm anti the fact that you need to look at your story and your background, because I'm telling you, when you arrive at perimenopause, each woman's got their own unique profile before they even get there, and that needs to be considered. So that's kind of what I started to work out.
Okay. And do you have any lasting situation from being on that high dose, and how long did it take you to get that sorted out?
So I started the process during COVID, which actually came along and was a blessing for me because I had to stop. Then I made the decision as I closed my business because of COVID. To be honest with you, I started to join the dots. in the research and I started to look at the fact that all my life I've ran away from the pain of my childhood. So even now I'm feeling emotional. So because I was forced to stop, this is what people probably, women with a trauma background or are more sensitive, we like to keep ourselves busy because we don't want to feel the pain. We don't want to feel it in our bodies, and so we avoid it. It's a trauma coping strategy. So I'm very much one of those people that just keeps learning and keeps working and learning and learning and working. You know, you'd say I was an alcoholic. I have been, by the way. I've done many coping strategies. That's a different story. And again, you start to look at the way you've coped over your life, right? And you will start to see the patterns. And that's what I started to do. And for the first time, I thought, okay, Paula, you're going to have to stop, right? And you're going to have to face it. And because of COVID, that gave me the opportunity. So I just made a decision to close my business and walk away and to start doing the work on myself. To come down off that HRT, then to come off the antidepressants took a year. So it wasn't an easy process because I then decided to come off the antidepressants after that. So again, I just had to go very slowly. So I always was like almost started at the top of the mountain and had to walk back down again. Instead of do you know what I mean? And that was a very, very, I want to say, traumatic experience, because we now know that trauma isn't what's happened to you, it's how your body and your brain processes it, right? So I'm going to say that it was traumatic. It was traumatic on an already traumatized brain and body, which is why I want to raise awareness of this.
Okay. So much to
that.
unpack. Yeah, there's so much to unpack. What would your advice be for women? Just trauma, no trauma. Just a woman who is feeling that she is early stages of perimenopause and wants to go get hormone therapy. Just that basic thing, how to approach it from a person who's been there.
So from a person who's been there, I mean, most of the medical consensus, if you look at guidelines, I've looked at all of the guidelines, would say that you would start low and you would give your time, the body and the brain, time to acclimatize, because we know that these hormones, right? The brain, it's a neurological transition, perimenopause, menopause. So your brain is adapting as well. So you've got to think about how your brain and your nervous system is interacting with those hormones. Does that help make sense? So it's low, allow time. I think that's one of the things that we don't do, we're maybe guilty of. And as a woman that's always busy, I would say I would be one. I just want to fix it. I just want to get well. I just want to get on with my life. In fact, I just want to keep being busy. That's not how the brain works. So you need to start low. You need to, I'm hearing horror stories of women starting on estrogen and then being told, because you're not feeling better, up it. I've spoken to women that are titrating their own doses of estrogen, up and down, trying to find up and down the ladder, adding more. That is, in my opinion, that's dangerous. That's not a good thing to do, because you're not giving your brain and nervous system time to adapt and then have an even playing field. Do I need to go higher? Should I come down? I think there's a problem there, personally, from what I've been hearing and seeing. And you've also got the other issue I'm seeing now. I'm seeing a lot more women saying things like, I'm on HRT, but it's not helping. There seems to be, have you seen that? There's a kind of like, there's more people saying, but I'm on HRT and it's not helping me, because potentially it isn't your symptoms that you arrived at perimenopause. If you've got a trauma background, you could be having trauma responses, complex PTSD. Hormone therapy isn't first-line treatment for trauma. I don't think people realize that. They think it was, it's not. And we need to get that message out there, because it's not first-line treatment. You've got underlying other stuff going on. So if hormone therapy is not working, I don't really think the answer is to keep increasing and increasing. I think we need to stop and say, right, what is this woman's story?
And I think we need to be clear that the guidelines, at least the ones I'm most familiar with, are the North American Menopause Society guidelines. You know, there's nothing in there about large amounts of, there's nothing in there with a prescription for how to prescribe hormones. Does that make sense? Like,
Yeah.
it is, as a layperson reading those, there is a wide range, a lot of latitude for error in the individual. And it's only through doing 3 years of interviews, looking at the research and talking to the people who are prescribing. When you look at what's happening in the earliest stages of perimenopause, it affects the axis in the brain that
Yeah.
handles how we deal with stress. And
Yes,
somehow I feel, and the research still needs to be done on this, that
it does,
this
because I've looked as well. Yeah.
this triggers what we have experienced. And I felt when I turned 42, where all of a sudden, all of the coping mechanisms that you had developed to deal with your trauma no longer
Yeah.
work.
Yeah.
And really what makes the most sense is what the integrative side does is when the progesterone starts dropping and the estrogen is still rising and falling, they go in and prescribe progesterone. And North American Menopause Society recommends progesterone for hot flashes, for mood, for sleep. And often that's a nice way to get into it. But you will know that the conversation is estrogen, estrogen, estrogen will fix every single thing. And I'm not
Yes.
sure brains like ours maybe are ready or capable of estrogen on top of already high estrogen. But this is a very nuanced conversation that you don't get. How do you feel about this? How do you feel
I
about
think
this situation?
so. Forget the trauma, even not.
Which we're going to
Let's
talk
take
about
women
that.
out.
We're going to get
Let's
to that.
yeah.
But yeah.
Let's talk about women. Let's talk about women that don't have a trauma background. If you take the personality trait, this is science, right, of the highly sensitive person, right? Now, 1 in 3 of us are born genetically with more sensitivity. We've all got sensitivity, but we're on a spectrum of sensitivity, right? Now, the highly sensitive people, shall we say, are born with a genetic trait and they are more sensitive. Their brain is more sensitive and their body is more sensitive and their nervous system is more sensitive, right? That's how you were born. Okay. If you then were born sensitive with that genetic innate predisposition, and then you entered an environment like I did that was a very unsafe childhood, my sensitivity is increased because of my childhood trauma, right? So I then become a very hypervigilant, hypersensitive person. Now, sensory processing sensitivity is what highly sensitive people have. They are more sensitive to their environment. So the nervous system is picking up external cues. Now, I've been looking at the research about hormones and how this interacts, right? No one's talking about this. This isn't a disorder. This is a personality genetic trait. So if I'm already more sensitive, right, and then you whack me full of estrogen, right, and my progesterone is not opposed, my brain and my body is going into overdrive. I'm already highly sensitive. So that should never have happened because it's way too much estrogen for my sensitive body and nervous system. But that happens way before perimenopause, right? But we know, because I've been studying the research, estrogen helps regulate sensory processing. So again, that has to be regulated properly in the brain, doesn't it? Because if you're too full of estrogen, it's like going mad. That's what happened to me. It sent me literally, the anxiety was through the roof, right? So people that are born more sensitive, none of this gets talked about. You need to realize that your sensory processing, you'll hear women, for example, their noise sensitivity increases. Yeah, because it's your sensory processing coming from the external stimuli through the nervous system and the brain, and then you've got your hormones interacting with that. None of this is being actually talked about, which is what I want to raise awareness of, because you need to understand where you lie on that sensitivity spectrum, because 1 in 3 of us are going to process, well, we process drugs differently. We're more sensitive. I've looked at the research.
How so?
Because we're already, our brains and our bodies are already more sensitive. We're taking in, it's coming from the external environment. So hypervigilance. Now, this is the same with trauma. So say you weren't born highly sensitive with that genetic trait, PTSD gives you the same type of nervous system, more hypersensitive, more hypervigilant. You're picking up cues before other people do. And I was talking about anxiety, and we talk about anxiety a lot in menopause. unless you've never had, anxiety is a protective physiological process, right? We're designed to have anxiety. People that are more sensitive have more anxiety, but it's a bodily thing. It's not a brain thing. It comes in from the body, the senses. The brain then starts to process that. Then you put the thoughts, the feelings, the thinking, and the meaning to the sensation. And then you start overthinking it. Then you start creating a loop that goes round and round. We've already got that before perimenopause comes along. So when we talk about treating anxiety with HRT, we need to understand that for some women, we've already got the we've already got that vulnerability, haven't we? So we need to make sure that if we're going to take HRT, that's one of the routes we want to take, because it's a great route for a lot of people, right? You start low and work up, because otherwise starting high is potentially going to tip that balance, that regulatory balance. And I don't know why this isn't being talked about, because there are side effects of having too much HRT. And I'm wondering now, as I see people talking about side effects, I'm wondering, well, could you be more sensitive? That could be an option you could look at, right?
Yeah. I'll see doctors say, oh, one of the questions I get is, why is my HRT not working? Well, your dose is too low. And then I saw a naturopath say, why is my HRT not working? I'm not feeling good. Maybe your dose is too high. The discussion is about whether to take it or not, and whether women have access to it or not.
But yeah, it's too binary. Yeah.
But I mean, I do think that there's probably a big influence, because this is a drug and there are pushes. So this nuanced discussion of the different emotional states of women, this is not
brains.
Suited.
Yeah, different brains for a start. Look at neurodiversity.
This is not suitable to the sale of a drug that you just want everyone to take and feel better. The sales pitch is, do you have problems you're in your 40s and 50s? It's hormone therapy, take it, everything will be better. And I find that is just such a one size fits all solution. And the people on the integrative side are the ones who say this isn't a plug and play situation. This isn't a one size fits all. And the people on the allopathic side usually aren't saying that. And I just feel like there's a big gap, and there's a lot of women in the middle. How did you feel when you go, you take it, you feel bad, you go back, and they say, take more? Like inside yourself, like how were you basically dealing with that?
I mean, if you think about it, I'm started on 100, which is the highest maximum licensed dose, right? But then I go back because I'm feeling worse, and it's doubled. So it's gone from 100 to 200, right? That's a huge that's a huge increment in itself, isn't it? I mean, we could be talking about anything. If you double something, then you're literally double, So, you've got to start to think about, well, how is my brain and nervous system responding? Because if you're more sensitive, you could get detrimental effects from HRT. That's what I'm trying to say. It might not work for you. It could actually be the cause of more problems, right? More side effects, more anxiety, more hypervigilance, more your nervous system's like, what the hell is going on? You've just pumped me full of, right? So I hope this is coming across, that it's not an anti-HRT. What I've learned is that I went privately, right? There was no conversation about me. Who am I? Right? Because, we talk about individualizing things, but I'm still saying, well, if you're not individualizing anything unless you understand that person's brain, because we've all got a unique brain, haven't we? We're talking now a lot about neurodiversity. And again, really, that's coming into play, isn't it? There's a lot of similarities, by the way, of being sensitive. One of the key components to ADHD, autism, highly sensitive people is sensitivity to sensory processing. That we share a common denominator there, right? Apart from ADHD is diagnosed as a disorder. Highly sensitive is a personality trait. It's not a disorder. But we do share some commonalities in the sense of how our sensory processing. When we look at the research over in pain science, for example, which I've been involved in for years, right? And we start joining the dots. What we're not doing in menopause is we're not taking any of the research in other areas and bringing it over to menopause. It's like, guys, over here in brain science, we've got a whole load of research about the brain and how it interacts with pain. because we know that pain, you can have pain without any tissue damage, right? So because I've been working over here in pain science, I'm like, guys, why are we not talking about this over here in menopause? If we cross the road over here to pain science and start dragging some of this research over, suddenly things change because we've got more research. But in menopause, we seem to be going down this very small lens of like, but it's menopause. Then we're kind of saying there's not enough research. Well, guys, we could join the dots, couldn't we, and take some of the research over here? Why are we not doing that? That's one of my big questions.
I thought about this recently because I've had IBS my whole life, or told I had IBS, and it blew up, and I had developed a whole bunch of problems from just living with it. But I got an app called Nerva, and I used it for 3 months, and it's a great app. It gives you a bunch of research, and then it's got hypnosis. And as I'm reading, it's like most of IBS has nothing to do with actually any physical problem, right? And using this app and doing a bunch of other things, I felt better. But I'm thinking like, this is a brain problem. And then it becomes a brain talking problem back and forth. And it sounds very similar to me. And do you think part of this problem, or do you see in this conversation, it's just perceived as a physical situation, menopause?
Yeah, I do. And what I see, this is what I see. So this is my perception, remember. So what I'm saying now is my own perception, right? Doesn't mean I'm right or wrong. It just means it's my interpretation of what I'm looking at. In some areas, there's a little bit of a kickback, a bit of resistance. If you say biopsychosocial, there seems to be almost like this kind of like kind of resistance to that. Like, what are you talking? Right. So with that resistance, I'm just going to say, if we go back over to pain science, which is across the road, and we knock on the door and we go in and we look at all of the research in pain science, that will start to tell you that the way that the brain works and the mind and the body, you can't separate them. You can't separate your thoughts, feelings, your beliefs, your nervous system, your brain, and your somatic symptoms, right? And because we don't look at that science over there, and I don't know why, and we have this kind of like this conversation in menopause, which is very narrow, in my opinion, the lens is it's kind of getting smaller and smaller, then when you say biopsychosocial, you get this kind of almost like, you telling me that my symptoms don't exist. It's kind of like this anger, right? There's this kind of like angry kind of response. Your symptoms do exist. If anyone says to me, you know, you don't know what you're talking about, you're gaslighting. And that's another one of my bugbears, gaslighting. So, I mean, it's so out of context, the way that this term gaslighting is used, right? I disagree with you. You're gaslighting me. It's like, wait a minute, guys. Wait a minute. Can we get this in? Because if you've ever been properly on the receiving end of narcissistic gaslighting, then you would not be using that term lightly. And it really frustrates me because people seem to throw it out there as if it's a kind of get out of jail card, isn't it? It's like, no, I don't want to take responsibility for my behavior. You're gaslighting me. So when we take symptoms, and we love a symptom, don't we? I mean, the growing list of symptoms in menopause. And I did have a little bit of an irk the other day because I thought, you know, I think I could say something like, my left ear is itchy. And if I put that on social media and I said it's a menopause symptom, it'd go all the way around the world, come back at me, and it'd be on the list. And I'm like, but who does the list? Like, who's the person? Who's the list collecting person that says, add that to the list? So we're in danger slightly of adding so many symptoms to the list of menopause that we're then missing out the fact that these symptoms could be of something else. That's what's called in medicine, there's what's called differential diagnosis, right? It's supposed to be a framework for clinical diagnosing someone. I'm fearing that in the menopause, we're not looking at the referencing of the differential diagnosis. We're not looking at the symptoms and going, okay, well, these are also symptoms of complex PTSD. So what we need to do is investigate a little bit deeper into what's your background, because as we come to perimenopause, this gets tangled up, right? And entwined. If we just say there's symptoms of just perimenopause, then you're missing the opportunity to understand how your nervous system and your hormones are interacting at this junction, and that it could be symptoms of trauma. Or do we just want to say it's just menopause? Does that make sense?
It does make sense. And also, we do have research that cognitive behavioral therapy and stress relieving tactics and practices diminish the number and frequency and severity of hot flashes and other symptoms. So I know this sense of like, you can't tell me that I'm not going through this, but I don't know whether it's like a sense of like, I don't want to have to deal with this. Like, I don't want to have to crack open and deal with all of this. So I'm going to claim that physical thing that's happening to me, and I'm going to fix it with this. That's somehow, I think, I can't explain that reaction, but that's somehow what I think is going on. But I'm troubled by the physical symptoms obsession as you are. I used to be into it in the beginning. I thought it was fun to come up with new symptoms, and I was obsessed, but I mean, it's infinite. But it troubles me because a lot of them, I think you should be getting checked out. If your hair's falling out, I think you should be getting checked out. I don't think you should be chalking it up to perimenopause. If your gums are bleeding, my gums were bleeding. I had a thyroid condition.
So my gums are bleeding because of allostatic load. Gum disease can be inflammation from toxic stress, from childhood trauma. Again, you just look at all the links there are, right? You don't just arrive there and go, oh, here's my list of symptoms. Well, you don't, do you? I mean, and it's frustrating when I see the mental health side of it being talked about in some such simplistic terms. And I see people saying, anxiety. I mean, I saw one the other day about menopause mood disorder, which is a label, right? Which is now, but what someone's done is taken a list of symptoms, right? Are you feeling isolated? Do you feel this? Do you feel like this? Yes. Tick, tick, tick. That's menopause mood disorder. Well, it might not be, right? It might be symptoms of lots of other things. And I think this is the danger of just keeping on saying menopause. Now, that's not to say that a lot of symptoms aren't due to hormone fluctuations in perimenopause, because they are, right? They definitely are. And it's not to say that you're not having symptoms, because women are having symptoms. What I'm trying to say is that there is loads and loads of research that could help us across the road over in pain science that we should be talking about. Because if you took everyone's brain and nervous system, we have all got a completely unique brain, like it is as unique as your fingerprint, right? If it was all down to the hormone fluctuations, we'd all have a similar bandwidth, I could argue, of the same type of symptoms, wouldn't we? But we don't, because some women have got far more severe symptoms. Now, there's research that suggests that if you've had childhood trauma, you are at higher risk of more severe menopause symptoms. Fact. That's what the research is telling us. But we don't seem to be talking about that, do we? Like, no one's really mentioning this. It's almost like we're all being lumped together and going, no. And then people are like, why is my, you could speak to your best mate, right? And they could say, my symptom of menopause is I have migraines. I'm suffering really bad. You could speak to another person at a dinner party and they're like, oh, no, I don't get any of that. I get this. So we'd all be sitting somewhere, wouldn't we? If we're around a dinner table, and we'd all be going, and then why have you got women that are like, they said to me the other day, actually, do you know, I went through menopause. I didn't even realize.
Or the women in Mongolia, or the women in
the cultural differences. Yeah. Look at the culture. So it has to be more than just hormones. And what we're doing is we're going progesterone, testosterone, and estrogen. And it's almost like these three amigos. And it's like, everything's down to these three. But they are interacting. Your body is made up of multiple systems, right? You are a human being made up of multiple dynamic systems. And so how your systems are interacting, your nervous system, your endocrine system, your digestive system, your musculoskeletal system, we could go on, right? That's a kind of bi-directional, isn't it? It's backwards and forwards. It's not just this is these three hormones and they just act in isolation, and that's why I'm feeling like this, because of these three hormones. I think we're in danger of taking it so small and narrow that we're going to end up not helping women. We're not helping women by narrowing the conversation. That's my opinion.
It's much bigger, and there's so much tied up into it. And it's a spiritual transition too. I mean, that's a whole other topic in feminist literature, looking at the shifting from this maiden who's used to pleasing everyone else and acting according to what everyone else thinks into, your own self, and moving into doing things more about how you feel and more about what you want. Mothers are going through this and shifting. I saw my own mother just sort of cared about me like a little bit less.
I did a post on this the other day about identity, because there's definitely a junction at midlife, right? Which you can choose to go this way. This is the way I go. Do you know what? Fuck it. I'm post-traumatic stress. I am going to grow. I'm always been about post-traumatic growth and healing. And I'm just going to be authentic. I'm going to be me. This is my time, right? Or, you can choose to see it as like a downward slope that's just slow, there's nothing you can do about it. And I just feel some of the narrative around menopause is this very negative downward. So there's nothing to do with whether or not you are having a really difficult time. I've had a very, very difficult life, right? I mean, I've had extreme challenges. And so do I choose to say, right, I've got to 45 and now I've hit this point and now I'm just going to let that I'll just slide into oblivion? No chance, because that's not who I am as a person. So I just feel that we can use it in both ways, and it's not saying it's not tough. And if people say, women say, well, you don't get it because you haven't. I saw this the other day, somebody put down about post breast cancer and not taking HRT, and she got annihilated. I mean, it was vicious. You're gaslighting us. Who's gaslighting you? She's not allowed to share her experience of a positive menopause and coming through breast cancer, and suddenly you're being gaslighted. I'm afraid that's the work that you need to do. It's not her responsibility of how you react and your triggers. It's yours, and people do not want to hear that. I'm not going to be very popular, am I?
Well, there's a major problem right now with people not wanting to do work on themselves and tell everyone else how to think and feel. And that's beyond the menopause conversation. That's just a out there conversation. Okay, so I want to get to trauma. Can you explain what it means to have adverse childhood experiences or trauma? Like what happened? What level can it be that you can be damaged, and at what age, and what happens to your brain?
Again, I'm going to take this back full circle, right? Go back to the fact that one in three of us are born more sensitive, right? So let's just say that. Now, sensitive is a word that conjures up like, oh, you're kind of timid, or you're sensitive, or it can be a little bit, it's not, it's responsive. Let's call it, we're more responsive, right? The brain and the body is more responsive. So if you were born more sensitive, the way your brain and body processes trauma is already different. So when we say trauma, you think it's the event or the experience, and it's got to be something that's, monumentally, like soldiers in war, right? In Afghanistan, right? We need to stop that, because it's not about the event. It's about how you personally process what's going on. So for my trauma, right? Now, I've had big T, shall we say big T, big traumas, right? So I've had lots of different things, but it's complex because I grew up with two parents that were mentally unwell anyway. So I was born genetically to two parents that, my dad was an alcoholic and my mum had eating disorders and lots of complexity to it. And there was no safety in our house. So I was the oldest of the two boys. I've got two brothers. And so I became the parent. Now, I became my dad's parent because he was an alcoholic. He used to confide in me. So he used to sit on my bed when I was a very young girl and tell me some really obscure stuff about my mum. She never intervened and said, you know what, he shouldn't be doing that. So I then became the adult. So I've never had a childhood. I've been processing stuff from a very, very young age, and then looking after my brothers, right? And then I was looking at, so I'm the cycle breaker. I would be called the cycle breaker in our family. And I'm going to talk about this on my social media. So physical abuse, emotional abuse, and sexual abuse. I've had all three. And the sexual abuse side of things is an uncomfortable conversation. And it's something I've pushed down. And I've pushed down all my life. But it's something I'm going to bring out in the open, because that would be what you would call, people think trauma is. They think that is trauma. That's big trauma. And I can understand why. It's got nothing to do with it. It's more to do with how you process that trauma. It's not the event. It's how you deal with it, how your body processes it. I'm going to give an example. I had a client, she was diagnosed with breast cancer. Now that's a big trauma. People don't think about it like this. That is a health trauma, right? So she's gone through breast cancer. She's come out of the breast cancer. She's on tamoxifen. She said, I've never been the same since, because her brain and her body is hyper vigilant because she is so worried that it's going to come back. That's trauma. That's a trauma response, isn't it? That is a trauma response. That's got nothing to do with childhood trauma. So when you take it backwards and you go, she goes, I've never been the same since, Paula, since I had that, because I've become hypervigilant. So your nervous system state changes to more fight flight. And when you start to stay up in that fight flight response all the time, you have what's called chronic anxiety. This is where anxiety starts, isn't it? Right? It's the nervous system state that you're living in, right? And I think what we've got to start to think about is, say you had a traumatic event. For some women, their child leaving home and moving on, that's quite traumatic for that person, especially if their identity has been wrapped up within their children or not having children, right? This is all, there's so many ways you can look at it, right? So say you are a mum and your identity has been very much geared towards being a mum, and then at this age, your kids or your kid or whatever decides to leave home, go to university, and you're in a marriage that perhaps isn't as fulfilling as perhaps it was, and then all of a sudden there's a big gap, isn't there? And you're forced to start looking at, where is my identity because my child's left home, and that's quite a traumatic experience for some women. And then they start to get more anxious, and then you've got perimenopause. Do you know, it's all linked, isn't it? You can't say one thing is trauma. It's not. And I wish people would start to understand that psychological stress, I'm going to call it traumatic stress, because if you say the word just stress, people poo-poo that as well. It's like, oh no, yeah, not just stress. Yeah, it's not really something. So we need to give it a bit more drama for people to understand the consequences of toxic stress or chronic stress on the brain, on the nervous system, and on your hormones, because they're all interacting, aren't they? And if you're more sensitive, you were born more sensitive, we already know that serotonin is lower, right? So you've already got lower levels of the feel-good hormone. This is what I think we should open the conversation up about more. How is it interacting? If we don't acknowledge that, then, and we go, well, it's just the progesterone, the estrogen, and now the new is testosterone. A bit like when you say, oh, my libido. Yeah, I've just gone through the scenario. If your child leaves home and all of a sudden you're in a marriage, you're forced to look at your marriage a bit more, aren't you? Because there's not that kind of thing in the middle that's keeping you binded together. That kind of thing that you've worked together at, and now it's not there anymore. And then you're wondering about your sex life, and, oh, we'll take testosterone. That is not going to suddenly bring your marriage back together, because it's far more complex than that, isn't it?
I mean, many people, I haven't ever been married or had kids, but I have friends going through this where you're married for 20 years. There can be a big basement of things if you haven't had good communication. And if you know that your marriage has a big basement and you're like, I could leave, we can open up the door to the basement. But either way, there's a lot of work to do. And so the stifling of that, the keeping that door shut, that is, I mean, I've been in long-term relationships where I've been in that place.
Yeah.
And it's terrible. And that was when I was younger. It's a terrible feeling, and not paying attention to the feeling that something needs to change.
The feeling, listen to what you're saying. The feeling is because your body is giving you a feeling. We spend most of our times up in our thinking world, thinking. If we were to slow down enough and listen to the body, we now know from the research, the communication is coming from the body up, from the bottom up. We spend most of our time in our heads thinking. We don't slow down. Then we're going, I need something to make me feel better, to keep going, because that's me. That's what I did. So I'm going to take this HRT and I'm going to keep going. Meanwhile, nothing else changes around you. You're still dealing with all these other complexities in your life. And then the HRT for some women will give them what I call a baseline. And that baseline is enough for them to be able to go, right, I need to look at myself. What's my exercise? What's my diet? That's brilliant, isn't it? Because it's giving you a baseline. For some women, that HRT isn't giving them that baseline. And then they're questioning, why is it not working for me? But we don't seem to be addressing the women that HRT isn't working for. It's almost like, well, you need to shove off over there, love, because, you know, we only want the ones that it's working for. It's like,
Ruining the
why
vibe.
why is no one answering them?
What about the ADHD piece? Because more and more, we're hearing more and more about how girls are so diagnosed with ADHD, and it's so much more than just not being able to sit still and irritating everyone when you were a kid. It's like, and so how does that piece fit in to this puzzle?
So I'm not an expert on ADHD, but one thing I do know is I was reading this really good book, and it was about sensory processing sensitivity. And I think I went back to that where I said to you, we share this common, if you're more sensitive, you're taking in more sensory stimuli, right, from the environment, okay? And your hormones also interact with your environment, okay? So we share that common sort of, ground, if you like. But with ADHD and neurodiversity, and this is an opinion, so I'm not clinically, medically qualified to talk about a diagnosis of ADHD. I'm just going to give what an opinion is. Because we know that the brain, every person is born unique, aren't they? The brain is unique. Like you haven't got my brain. I haven't got yours. Our architecture of our brain is unique. So could we start to think about actually exactly that? We're all neurodiverse. We're all on a spectrum, aren't we? I mean, what's normal? Who said, who was the man, probably, put that bit in, that said, this is a normal brain? Well, how do you know? Did you analyze every single who's done all the? So what we've done is put people in these boxes of saying, this brain over here is the normal brain. But as we're starting to realize more about the brain, we're starting to go, actually, we're all on spectrums, aren't we? I think we're all on a spectrum of neurodiversity. And therefore, if we start labeling it, so now we're going, well, ADHD and then autism.
I can't stand hearing normies, because what does that mean? You get to be normal.
There is no normal. That's what I'm saying. There's no normal. What's the normal brain look like then? Who did all the stats on that? If we start looking at it from, we're all on a spectrum of multiple different things. That's why I keep saying you've got to think about the role of the brain within menopause, not just the role of the ovaries and the sex hormones. Look at Lisa Moscona, and she's talking about, but look how it's a neurological transition. So depending on how your brain's wired, you're going to have a different experience to me, aren't you? Perhaps that's the reason why, I'm not saying it is, perhaps one of the reasons we have different experiences as well is because of the spectrum of the brain in itself and the neurodiversity of women. So let's talk about, the fact that we're all neurodiverse. Not now, that's not saying that, because obviously ADHD is a clinical diagnosis, that needs to be diagnosed by a psychiatrist, right? And perhaps that was always there and we've always had that, but it's not been recognized, and now we're starting to recognize it more. And as women are coming definitely to that perimenopause junction, it's the same with highly sensitive women, because of the changes and the fluctuations in those hormones, it seems to exasperate what was already there. It's not the cause, it's there, but it exasperates it. I would say that rather than it's perimenopause and everything's down to this hormones. It's not. It was already there. And now this is being highlighted, a bit like trauma. It's already there sitting, right, in your nervous system. We know from the way that the brain and the memories and all of that, you're pushing it down, you're pushing it down, you're pushing it down, you're keeping busy, or you're just coping, because as women, that's what we do really well, right? We're really high achieving copers in life, aren't we? Most of us. Maybe we just get to the point where we go, my body is telling me I need to listen, and we're not listening. And that's not to say they're not symptoms, they are, but they're also messages, aren't they? Of what deeper, maybe underlying stuff that you need to think. So I think in neurodiversity, we should open it up and say we're all neurodiverse. Everyone's got a unique brain. So show me the studies that say this is the normal brain, because we're all on spectrums of something. That's always been my thing. Do you see what I'm saying?
100%. And people will get angry if I say it's an opportunity, but it is an opportunity that you can't ignore. I hit it myself, and it's taken a long time to unravel.
Yeah.
And it's been a long, painful process, but I'm glad for it, because I'm feeling a freedom unraveling it as I move through. and I'm feeling my feelings, and I'm doing all that stuff, all that happy stuff that people will make fun of, but it is an opportunity for me to come back to myself and feel emotions, feel.
We're avoiding feeling. We don't want to feel. It's painful. Feelings are painful. So we shut them away in a box and we try to compartmentalize them. But the brain doesn't work like that. It's stored away. It doesn't go anywhere. These physiological processes and trauma and all of that, where do you think it goes? It doesn't just evaporate like in thin air. Like I used to think, I'll just avoid it and then I'll keep going and I'll keep going. And then, you know what, actually it comes back up. And I think it comes in that midlife junction, and you'll see it with men as well. So let's not just say it happens with men. What's, you know, what we call the midlife crisis. We're human beings, aren't we? It's far more complex, I think. And I think if we open the conversation up and broaden it, we are going to help more women, because more women are then able to say, you know, you're right. I've been feeling like this, but I didn't want to talk about my feelings, right? Because it's too scary. It's too painful. I don't want to go there. And my body is giving me these sensations, but I don't want to feel them. So I want to avoid them. And, you know, I think if we open it up a bit more and we acknowledge, it frustrates me that medics don't talk about trauma. I mean, why is that? Because we've got the research. I don't know why. Is it because HRT is not first line treatment for trauma?
I have no idea. I mean, I just don't think it's very ingrained. I just don't think it's ingrained in the allopathic medicine model to talk about it, but it should be. It really should be.
In the States, I've got them, in the States, they've got gynecology, trauma-informed gynecology, because they're starting to work out that we're seeing women with pelvic issues or around that area, that trauma. So they are, I've been looking at all of the, so how come it's trauma-informed in some places and not trauma-informed in others?
But how come I'm seeing trauma-informed therapy? I mean, all therapy should be trauma-informed therapy. Like, if you're not informed about trauma, I don't know why you're doing therapy, but it sort of leads you to believe that there's some therapists who aren't dealing with trauma. So I guess it's just a slow process to realize and then implement and get the message out. And this hormone therapy conversation right now doesn't help because it's so binary. It's so physical. It's so
broad enough, is it? It's not broad enough. It's not, you know, perhaps we could answer the questions about why some women may suffer more severe menopause symptoms. Why is that? Well, trauma is one. There may be multiple other factors, right? And other things, but otherwise, you know, if we're not talking about that being a risk factor, because it is, because we've got the research, you know, if medicine's not acknowledging that in the way that it's not trauma informed. I mean, I've been on the government website, you know, the UK government, trauma, we're talking about trauma informed, and yet menopause, we're not talking anything trauma informed. It just isn't there. So if we want to be modern women and take this conversation into the new modern way, why are we not looking at the modern research on it? Why are we still looking at old research?
And I think from my experience and from other women who've made it through to the other side, if you can deal with all of this, you're going to set yourself up for like a much better life. Like, you're going to set yourself up and process all this stuff. So my question to you is, what do people do if they're listening and they're like, this sounds like me, this sounds like me? What I know, it's like when you have 1,000 steps to take, like, what direction do you go in? Where do you go? How would you start again if you could do it again, knowing what you know?
So this is something I'm working on at the moment, because if you have a common denominator with, so a lot of people can't access individual one-to-one therapy. I do individual one-to-one therapy in which is cognitive. So it's not just the talking, it's the body and the brain. So I do somatic work. That's why my brain body thing is all around the brain and the body, because we can talk, but when it comes to trauma, we know that the talking therapy is nowhere near as useful as the body, right? And you don't even need to talk about your trauma, because sometimes rehashing trauma for a lot of people is really traumatic. So I'm looking at setting up, that's what I'm doing at the moment, a group option, low cost group option. So I can take women in every week online, and I can start going through some tools and resources, right? So that you learn how to use the tools and resources. That's different from you just doing them. What do they mean to you? How can you, because on social media, right, I can do a video of a somatic tool, right? It doesn't mean you're going to be able to, without guidance and a therapeutic approach, because half the thing about therapy is the relationship you have with the person, your therapist, isn't it? So I was thinking about doing a group offering where I can say, right, sensitive women with a trauma, but that's what my niche is. I'm going to open this up. We have a community, or we'll have a group that you can come. It's once a week at a much lower cost than you would have to do one-to-one therapy. And then you can start to learn some of these tools, all the things that I've learned. Or I'm happy to, obviously I have to charge for it because but it's not about that. It's about, why not all the stuff that I've learned and I'm doing, I want to give it out there and back. Because really my people and the clients and the people that are me, aren't they? They're kind of like, that's what I've been basing this on. I can't be the only woman, who's struggled with trauma, who has a sensitive nervous system, who's had to work it out. And because I've worked it all out, I'm happy to then say, come on then, let's share that working out. Because we don't do a lot of working out, I've noticed. It's almost like, honestly, I can't tell you, once you work something out and you have the awareness to it and you understand it, oh my God, that's even half the battle. Understanding why you're feeling this way, understanding it, because it changes everything when you start to become more self-aware about yourself. And one of the things that we definitely have in perimenopause is, for some women, is a loss of identity, of self. So when you talked about that spiritual connection, for some women that does feel spiritual. It feels like a connection back to who I'm supposed to be. My identity is being wrapped up in multiple other things, and that sense of self is so powerful that I'd like to promote more of that growth, and that, rather than it being just the end of the road. It's like, I can't bear this kind of end. No one's talking about, it's not to do with HRT, is it? Like, you can take it, I take HRT, so it's nothing to do with HRT. What we're talking about is to do with you as a woman and what you're doing with your life and what it means to you. And can you step into your authenticity and your truth? And can you be bold? And can you do the shit that you want to do that you've never done? What's wrong with that conversation? That's psychology. That, rather than it just being, the menopause conversation now has just become, do you take HRT? No. Why not? Oh, you're gaslighting me. It's just like, this is one conversation. It needs to be much bigger than that. I can think you can hear my frustration, but hopefully that's coming across as passion rather than, anything else.
Is there a book or something, a resource in the meantime, that you can recommend for people to sort of wrap their head around how trauma is connected?
So I think this one, which is really easy, and this journalist is really good, is this one. It's Janara Nerenberg, and it's The Divergent Mind, right? And it's thriving in a world that wasn't designed for you. Now, this is about sensitivity. And what she's done very well is joined all the dots with your sensitive nervous system. Some women have more sensitivity, and it's really giving you more insight to that. And I would start looking at whether or not you're more sensitive through either trauma, or you were just born more sensitive. You have more emotional depth. You process the feeling of emotions in a different way. I think understanding that is a really good start. I would recommend easy reading, and she's absolutely brilliant. And she references the brilliant Pauline Mackey in here, who's the who I listened to the other day. I just think she's brilliant, talking about Alzheimer and dementia. Her work, there's no fear mongering. It's very, she's authentic. She anything like that. These types of people, these are my people. Does that help?
No fear, just understanding ourselves.
Let's not scare everyone into there's a difference between what I call fear-based marketing and medical data, and a lot of it's being mixed up, isn't there? Like, this is medical marketing. That's very different from medical data, and sometimes what you're seeing is just medical marketing without the data behind it to back up the medical marketing. If you rub it away, like it's like the Wizard of Oz, like open the curtain up and then all of a sudden there's not much substance there behind these some of these claims. And because I'm a big digger, I'm like, let me investigate. Well, you must know that. You must have that type of brain where it's like, let me join these dots. Let me joining dots.
And this idea that things just become illusory truths, they're just repeated by everyone, and social media is a disaster for this. So everyone's just repeating things that aren't true. They're claims, claims about hormone therapy, claims about menopause. And when you dig down into them, they collapse. You're exactly right.
You've got to dig. That's what I did. I started digging and then I started joining dots, right? And because I do the digging and the joining dots, I'm happy to share all the stuff that I've learned, because I'm like an encyclopedia of learning stuff, because I've gone through the process myself, right? And I think that's really important because it's authentic. You're talking about your lived experience and your professional capacity, and you put them together and you think, I can't be the only woman that's feeling this or thinking this way. And I think when you look at social media and you look at, again, there's a thing called tribal psychology, isn't there? We like our tribes, we belong in tribes. We want to be part of something, it's a feeling, again, a feeling of belonging. And so if there's a camp over here that's saying, these women are all the same as me, we want to go there because it's safe. It feels safe for us. And we've got to dismiss the fact that, sometimes it's like, it's not so black and white. We're moving up and down a spectrum and we're going, that makes sense to me, but this doesn't. But that's okay. It doesn't make sense because I don't feel that's right for me. We're not tapping into that feeling. We're kind of just being told, it's HRT or nothing. That's how I see social media at the moment. And I think that's a very, very dangerous road to go down.
Yeah, we're not developing our own intuition that we've sort of suppressed.
We've all got it.
Right?
Yes.
And then coming back, but we're suppressing it again. And this is not, I don't feel it's doing us any favors. It certainly doesn't do me any favors. I'm trying to build my...
Exactly. If I'm working with somebody, I never say to them, you should do this. I always bring it back to how do you feel? What do you think? And do you know what? It might take a few goes, but we already know the answer. We know. Right? But it's just being masked with these layers of complications of other people's stuff that they want you to see. So then you're, I'm not sure anymore. But you know the answers. Deep down, we all know our own answers for ourselves. And that's your innate wisdom, your gut. That's how the gut and the brain connect, isn't it? Right? And I always think to myself, what's my gut telling me? Because my body feels it. And that's what I go with just before my mind starts kicking in. And then I start reading more on social media. And then all of a sudden I've changed my mind because I've seen something that I've listened to your gut. It's telling you the answer. It's like, ooh, that doesn't feel right. Ooh, that feels right. And I think that's the thing that I think we've lost that anyway, because we're so out of touch with our bodies. I mean, I certainly have become disconnected. That's the word I use. And I think women in menopause or perimenopause realize I'm disconnected and I need to connect back to who I am, what my values are, where I sit in my authenticity, who I am as a person, and what I want to do with the rest of my life. There you go.
That's a good sound bite, Paula.